Well, thank you for the opportunity. Actually, it is a great opportunity for us in order to interact and to know each other. Here you can see our venue. Karim is a little village with some churches from different aspects. Actually, you can see the Orthodox, that dome is the Russian church, and many others. There is a special importance for this village and the stories about Mary. Anyhow, this is Hadassah, as it is shown here. Can you see my pointer or you don't?
Yes, we can see.
Okay. So this is the so-called old building that is now being in a process of rebuild, and this is the new tower, which is the hospitalization tower. This is one of the air spots where helicopters are landing, but it was designed in a very open space and windy, so it is less used as it is programmed in the beginning, but we have an alternative. I'm going to let you know about our Liver Institute in Hadassah Medical Organization, and will appear frequently as HMO. Actually, I'm starting to define myself. I am an expert in internal medicine and gastroenterology, pathology. Actually, my medicine studies until now are all in Hadassah. I'm in Hadassah almost 40 years for all. I've been in sabbatical stay in Mount Sinai for a couple of years, 2001 and 2. There I worked with Professor Scott Friedman, and since that time I'm actually researching the hepatic fibrosis issues. I'm full professor, and as you see, my publications, over than 200 now. Many of them are related to the NK cells and hepatic fibrosis, being colored accordingly. I used to be the chairman of the Israel Association for the Study of Liver for about 3 years, and now I am in the governing board and treasurer of the Israeli Society for Gastroenterology Liver Diseases. However, I used to be in the scientific committee and governing board member of the European Association for the Study of Liver, 2007 until 10, and I used to be also in the International Relations Advisory Committee member in the AASLD for a couple of years as well. This is a short survey about my activities. I am running a Fatty Liver Conference, International Conference on Fatty Liver. This is the third one. We ran it in Vienna last April. We are doing that for 3 times already every 2 years. Corona did it last time 2.5 years, but now we are renewing the activities. This is the structure of my Liver Institute that I took it from the beginning what I had, and I did some modifications and enlargements. It is not a mistake. When I have been introduced earlier in this speech, it was introduced as liver unit. Indeed, we enlarged the service, we enlarged the outcome, and we are now defined by the administration of Hadassah as an institute instead of unit, with many of the related outcomes. So mainly I have on the right the clinical service that I will explain about the spectrum of clinical diseases that we are treating and challenging. And I will also show you some of my activities. We have a research lab, basic lab, and we have a service lab. Regarding this research lab, I have several groups and I have several projects, and I'm going to extend later on about the green one, the NLG4. Actually, I am focusing within the immune regulation of hepatic fibrosis, and specifically looking at the natural killer cells and how they should kill the fibrosis, clear fibrosis, and what happened to them in the case of fibrosis progression towards cirrhosis, why they impaired, and how we can achieve the so-called rehabilitation of the NK cells and NK cell immune therapy. So I will start in this part with the lab service that I'm providing. The fact that I have a research lab, I also offer my service for many initial companies that they do have compounds that are offered potentially for my field to treat, for example, the fatty liver disease, which is the most common that we face it right now. And in this case, the companies who are in the very early phases are coming to me. So I do for them a proof of concept that their compound is effective in the in vitro setting, then in the in vivo models with animal models, and then I'm running for the early stages and phases for clinical trials in human. Not all of them are becoming medication and becoming to be included in clinical trials, but I brought here in 3 samples, Oramed, Chemomap, and Canfight, that really we were likely to succeed the drug development from the in vitro setting, the preclinical, until the clinical data. And after the early phases that I'm running with them, they are flying with their own wings, continue their way. And this service I'm providing usually by contacts and contracts. And so far, those are not successful without the involvement of our Hadassah. Hadassah is our so-called commercialized body that is actually doing a very important work that is taking our research results for patents, connecting us with companies, and doing a very important work in order to bring the translation research to the theater of actually treatment therapeutics. So it is very important, and we're working closely with both the research and the service lab as well. I also offer a unique serology testing. The simple viral serology, for example, the hepatitis A antibodies, hepatitis B and C, is very simple and cheap, actually, the routine service. However, I have a very unique service to assist serology in very unique situations that are actually having the validation to be used for drug development, and therefore Kamala, Cytogene, or Donisharim, and other omics, all.
El último ya. No, ese no. ¿Lo guardo? ¿Y la mitad?
Sí,
A ver si
apague el
se
micrófono.
Can I please ask people to, everyone to close their microphone?
Apague el
Please, if you're
micrófono,
not
por favor.
talking.
It's that we disconnect. Do you hear me?
Yes.
Just see my presentation.
Not too well.
Okay. It looks like some disconnection happened, so I will try to do so again with sharing. Just a moment, please. Okay, do you see the screen again, please?
Yes.
Okay, thank you. So in this case, those companies are using the blood products and the blood units from the blood banks, the ones that are expired and are not used in clinical use. Those companies are using them for producing the antibodies that we are treating our patients, IgG, for example, and medical glues. And they have to be sure that there is no serological evidence of viral hepatitis, so they cannot use the very routinely simple ones, and I provide for them the qualified tests in order to have the certificate for marketing their products out of the country. So all of these are actually done with the Hadassah that I just mentioned, which is our commercially a body in Hadassah connecting us to many commercial companies and others. We also perform the service. We offer the service of FibroScan that I guess you have it and you know the service, which is the non-invasive tool to assess hepatic fibrosis and steatosis, which is the bedside actually test ultrasound like that is assessing the fibrosis scoring, staging, and the steatosis scoring. We have the three probes, the children one, medium size, and the extra large one. Now I'm going by clinical service and going in detail what we are doing. Actually, every day I have about 50 liver patients are hospitalized in Hadassah, HMO. And when I'm telling you about Hadassah, it is actually two campuses. The first one that I showed you in my first slide, which is the NK campus, but we have also the Mount Scapus campus. Mount Scapus campus, Haratufim we call it. It is the east part of the city. We are in the western part. And altogether, we are hospitalizing our patients in both hospitals, both campuses. We have an artificial intelligent facilities, and every day, 6 a.m., have the list of my patients who are hospitalized everywhere. I have the list of the medical characterizations of the patients, personal characterizations, where are located in which departments, which beds, and what the diagnosis is. And therefore, we are actually providing the consultations. Most of them, we are giving the consultation from far without the face-to-face meeting to our medical teams. And in some of them, we do the round every day, and we have once weekly the grand round to see most of the difficult patients that are hospitalized. And mostly we are hospitalizing patients or those who are with the fibrosis and cirrhosis complications, or those that we are hospitalizing ambulatorily in order to prepare them for liver transplantation or any planned procedures like TIPS, TIPSogram, and so far many others. But also they are hospitalized by emergency basis from the ER emergency room, and therefore we can allocate the new patients that did not follow up before, and we have also our patients that are hospitalized. A part of the inpatients, the hospitalized, we have the outpatients, and those we are actually see them in two bases. The first is the clinics, and the second is the I would say the multidisciplinary teams, and there is some kind of overlapping. Clinics, it's covering the whole spectrum of hepatology, that is to include the general pathology, the mother to child health, the viral hepatitis, immune and cholestatic clinical trials, that is including the fatty liver, and actually it is kind of reflection of the fact that we had a lot of viral hepatitis patients that we were challenged to treat and to vaccinate. All know that globally we have 325 million of hepatitis B and C carriers. Luckily, in Jerusalem, this is one of the early studies that I did in Jerusalem, and we showed the hepatitis B carriers. We see that the Arabs are more prone to be carrier for hepatitis B as compared to Jews. But also Jews, it depends from the point of view of origin, where are coming from, and this is also dictating the risk to have hepatitis B. However, luckily we have the vaccination for hepatitis B that have been introduced since the 1992. We have the NOx, the nucleoside analogs, little use of interferon, which actually could depress the virus and prevent the cirrhosis progression, even to improve the cirrhosis and prevent the HCC as well. Same thing with hepatitis C, that used to be a very strong challenge, and all of us aware of the novelties that we have it already since the 2014. The new treatments, the DAAs, in which we have a very nice successfulness with almost nothing side effects, and many countries did very well. Actually, we are not in this study showing in the map, although I am one of the contributors. However, we did a very nice job in order to reduce the burden in Israel, but we still do many efforts. However, all we know about the fatty liver disease, that is becoming the bigger challenge with its progression from a simple steatosis, NASH, and cirrhosis, with all the points in the middle, and the metabolic equally all over metabolic syndrome, not only the liver. So this is the challenge. It is again reflecting the clinical trials that we are running. You can see that the most of the clinical trials that we are running, they are in the field of NASH. We have many studies that we are part of the international studies. Some of them are part of our initiatives, either therapeutic, but also we have many diagnostical biomarkers that we are in development stages with or without collaborators. We have also some studies in the PBC, PSC, pruritus, Wilson, hepatitis delta virus, and hopefully we will have more successful outcome of those studies and to be translated to the patients directly. By this means, I summarize for you the out clinics, but I also want to show you the groups or the activities that are demanding multidisciplinarity. In this case, I will show you the HCC, portal hypertension, liver transplantation, and many others, then followed with metabolic units, hepatobiliary, hepatopancreatic biliary, but I will extend the explanation about the first three from those lists. So HCC, hepatocellular carcinoma, is actually
No se escucha.
No.
Professor Safadi, we lost you. We can't hear you.
Yes, I don't know why. It looks like it is intermittently lost. But again, I'm so sorry, and we will try to
We just lost the last 20 seconds, maybe 15.
Okay. Do you see my presentation again now?
Yes.
Okay, thank you very much. So this is the multidisciplinary team that we have with the HCC. That is including ourselves as pathologists, the radiology experts, the imaging or diagnosis, and the interventional ones, the transarterial chemoembolization, radioembolization, the radio frequency. We do not use anymore the alcohol injections. We used to do so in the past. Oncologists are becoming a prominent partner in this case. Just at least a few years ago, we had only the sorafenib, so we didn't need the oncologist in order to recommend the sorafenib. However, now, luckily with the new
Ya.
Oye, a lo mejor.
for that.
Oye, apague los micrófonos,
I'm back,
los micrófonos.
and sorry for the the disconnections. So we all meet once weekly, actually, to discuss our patients. And we all working with the well-known guidelines that are known for everybody regarding the therapeutic options. And so far, we have very nice results. Then I'm going to discuss with you the portal hypertension unit, which is including our partners angiography for diagnostic angiographies and for the TIPS, TIPSograms, and BRTOs. We are doing a lot of BRTOs recently. Those patients mainly with the gastric varices and are not eligible for TIPS, as well as the daycare facilities that they are very helpful to manage patients with ascites, in particular intractable ascites with or without renal complications. And the Gastro Institute, where we used to run our endoscopic treatments, banding, as well as EUS, endoscopic ultrasound coiling of gastric varices. So this is kind of another model of collaboration, multidisciplinary one that we are running. And for sure, the most active and challenging one is the liver transplantation. Brought SPY, which is an old just to show how we were busy at that time with viral hepatitis B and C as main causes for liver transplantation. However, this part of pie is diminishing, and now the liver disease becoming the main actually game for indication to bring patients with liver transplantation. So we are collaborating with the surgeons, with the anesthesiologists, with the psychiatrists, as well as the psycho. And actually, we are collaborating with a very unique and special team from cardiology, same team that is dedicated for liver diseases that are very helpful and collaborative to run the very, I would say, unique studies in the echoes, the cath, left cath, right cath, to assess the pulmonary pressures and ability to be a candidate for liver transplantation. We also have a big support from our different ICU units. that are really supporting us very well, as well as we are doing that with the important help of our ER emergency room that is locating our patients and recruiting our patients in emergency situations. And we are well connected, discussing the patients every week. We are in Israel. Actually, we have the program for solid organ transplantation that is controlled.
Maybe you should close your camera.
My camera, you mean?
Yes, I guess will improve our connection. Maybe.
Okay. Okay, we'll do so.
We want to see you, but I guess.
Okay, so I'll try it. Thank you for suggesting. Well, anyhow, we have a control from the Ministry of Health for allocation, the prioritization of the liver transplantation. We are working according to Melbourne, and we are 3 centers in Israel, and happy to be one of the most active centers for liver transplantation. It's very challenging, as you know, since our patients became more and more with fatty liver disease, with many of the metabolic sequelae that is making them more difficult to treat patients as compared to the ones we used to transplant a decade ago or more. And so we are facing very real important challenges. We are preparing the heart with TAVI, with the cabbage. Before liver transplantation, we had a case in which 3 TR, tricuspid regurgitation, have been fixed by clipping, angiographic clipping, and then pulmonary hypertension actually improved, and luckily underwent liver transplantation. And so far he is 8 months after liver transplantation with very good shape and function. So now the recipient is difficult, but also the donors are difficult. Our donors are more and more sick and more fatty, but actually the last line that we are working in a good collaboration with all facilities that we have. We are supporting the communications with very good results that is actually mimicking the international ones. Finishing my clinical presentation, and before going to the research and the basic research and what I'm doing in hepatic fibrosis and immune modulation, I will stop for a period of time in order to have some discussion, if you wish, questions, answers, and then I will continue with the research part.
Mm-hmm. Yes.
So, Dr. James?
Yes, yes, of course. Please.
We get the permission to make some questions.
Okay. You know,
About
Professor, about the
well.
institution. You know, I would like to ask, you know, how many meetings do you have a week in your liver unit? I want to see you.
Well, just a moment. I will open the camera to take the look at least. Where is it? I lost the camera. Where is the camera? Well, anyhow, Mondays we have the HCC multidisciplinary meeting. Monday I have the gastro meeting, the hepatobiliary and I have my general hepatology and transplant meeting. We have also same day, Monday, I call it DVT prophylaxis. I have to take Lexan before. We have also the meeting with the medical internal medicine division, in which our patients are also presented and we are participating. Wednesdays, we have meetings with the surgeons for the patients who are at the top of the list liver transplantation, and we have by end of the week meeting in order to actually summarize the weekend. We have small meetings with the internal medicine department, not the division. So it is a lot of meetings, a lot of time that we are spending there. Yes. But this is the way how we do manage to cover all those patients that we have in the in clinical and out clinical services.
Okay, thank you. And the other question, what time do you start to work and what time you finish to work every day?
Myself or my team?
You and your team.
Well, myself, I'm starting my work 5:30 a.m. and even 5.
5.
And leaving very in the evening. Well, my team is lower, and this is very important actually issue, since you know that most of the hepatologists are gastroenterologists, and myself as well. And gastroenterologists, when comparing the work in gastro and lumen and instruments and the income as compared of the struggle with the very difficult to treat patients that we have in the hepatology, so you end with many experts potentially for the liver, but they are not practicing the liver. And need to recruit hardly human resources, medical doctors who are experts in order to agree working in such kind of situation. It is not easy to recruit hepatologists to transplant centers actually. That's why, for example, in the US, they are mostly or Indian, Pakistan, or anywhere, as you know, and less Native Americans.
Yeah, I know. You know, in Israel, the hepatology can be a unique specialty, or you have to be a GI doctor?
Well, by definition, it is part of the gastroenterology as specialization. However, as a department, unit, or institute, in different hospitals, it is sitting with different dependency. And actually, we are in parallel to the Gastro Institute, our Liver Institute, and we are working closely, and we are exchanging the fellows that they do have the program to be in the gastroenterology and hepatology in different ways. For example, the fellow should do every 1 year of the 2 years, a whole month in the Liver Institute in order to be exposed to the very difficult to treat patients who are hospitalized. Moreover, there are consultants who are fellows that they provide consultation in general gastroenterology and hepatology. They could not see the liver cases. They are very busy with the gastro cases. I try to push them in order to be exposed as well. It is not easy since the demand for gastro consultations and mainly the demand for approving or declining the gastro instruments within hospitalized inpatients is very challenging for those fellows. So we are trying to do that together, and actually our fellows are well exposed to liver fertility.
Mhm. You know, and the ACC, who is treating with the new medication? The oncology or the liver doctor? With atezolizumab, for example.
Okay, with immune therapy, we are actually right now keeping the privilege and treatment for oncologists. We are having the meetings together. Mostly the patients are coming from our facilities, from the pathologists. Since we have the patients, we screen the patients, we surveillance the patients, and we support the treatment of cirrhosis and cirrhosis complication. So the patient is treated in the onco facilities in the cases of immune therapy, in the cases of TER case, they are hospitalized in internal medicine. TER, radioembolization, they are hospitalized in the special covered rooms, protected rooms in oncology. So we are sharing, and actually the patients are attending both clinics. We could not run common clinics in which both oncologists and hepatologists are sitting together to see the patient. We see it more efficient to let each doctor see his own patient and his own expertise alone. It is kind of privacy, and it is more efficient actually.
Thank you. Somebody want to ask any question? Carol?
Yeah. Yeah, thank you for the presentation, Dr. Safadi. I'm Carol Beltran. I don't know if you can hear me.
Yes.
I hear you. Yes, I'm trying to reopen my camera. I don't find it.
Yeah.
Well, here it is. Okay.
Okay, here. Okay, thank you very much for everything. I can see, you have a big institute and big, wonderful collaboration also inside them. I am Basque Clinic Research. I'm doing actually some grants and some projects related with immune response in gastroenterology. Yeah, I'm actually the one, a principal investigator of the immunogastroenterology lab in the unit or the gastroenterology unit. And I'm very interested on some things that you mentioned about the immune system related with the liver diseases. Mainly, if I understood, you mentioned NK research or something. I don't know, because the connection was a little
Yes, Carol, I would love to keep your question after presenting my research work. And,
yeah.
I think you will find a lot of rooms for collaboration.
Yeah, that's the point.
So if there are no more questions, I will move forward.
Okay. Okay, please.
This is the part of research lab. I'm going to talk with you about the NLG project, but I think that your demands fit the NTCP one that I'll also tell a little about it. Actually, we have applications, we have targets, we have medications that are being developed and are in development. This is with our own team, but also collaborations. I'm collaborating with cardiologists right now when the liver is meeting the heart. I have an international collaboration with China, but also with the US and Canada and Europe. And by far, going to the hepatic fibrosis, this is a cartoon drawn by my mentor, Scott Friedman, many years ago, which is the interaction of the myofibroblasts that are called ETO cells or hepatic stellate cells in order to convert it from the quiescent to the activated form and actually producing the hepatic fibrosis. Among many pathways that are activating the hepatic fibrosis, leukocytes, immune cells are one of them, including chemokines and toll-like receptor ligands and other ligands, I had opportunity to discuss a little bit or to research a little bit the tool-like receptor 9 that I'm not going to mention here but actually we are more focusing with the lymphocytes. And if you look at the intrahepatic lymphocytes and the subclassification, natural killer cells are the dominant ones within the liver, which is actually not the way in the peripheral blood. In the peripheral blood, it is only 10% maximum. However, inside the liver, up to 45% of the liver lymphocytes are natural killer cells, and this is the reason why I focus in NK cells in hepatic fibrogenesis. The very early situation, about almost 20 years ago, I published in gastroenterology how CD8s and another T cells are activating the stellate cells to become fibrotic, and how the stellate cells become to be divided to 4 subpopulations. But later on, I focused within the NK cells, as they are actually should clear the activated stellate cell and to protect us, to have anti-fibrotic protection against the fibrotic tissue that have been accumulated. And this is the good guide that we have to keep. However, its function might be missed, and therefore fibrosis might progress. It is not only the number, but also the functional capacity of the NK cells, and there are many definitions to activate and to define the activity of those cells. Actually, we showed very early, 2006, that the activated stellate cells are losing DMHC class 1, and therefore the NK cells define them as actually correlates and as a target that should attack, and in this way the NK cells are attacking the activated stellate cells, activated fibrotic cells, myofibroblasts, and causing to the death, apoptosis and death of the fibrosis. And this is the anti-fibrotic property that the NK cell does have it in normal setting and normal situation. Later on, together with another collaborators, we actually found out more and more immune killer receptors within NK cells that are participating this game. And we actually, as well as others, I will show you all other studies, we showed that something bad happened to those NK cells. In this up figure, I show you that in fatty liver disease, in x-axis, the more fibrosis staging, the higher fibrosis staging, you can see that the NK cells is changing the potential to kill. The activation might be impaired. At the beginning, F1, for example, in the early stages of the disease, when the early fibrotic tissue is activated, the NK cells are activated very high as compared to the healthy, and they are killing the target, which is the myofibroblasts. However, along the time, they are impaired and they are losing their capacity to kill. And you can see that in the HCC patients, the NK cells are not moving, they are compared to the non-activated ones in the healthy. So this phenomena, which is have been published by our group as well as another groups, we were supposed to explain why it is happening and how we can cope with it and to fix it. So I went to my HCV patients at that time from different stages, and I thought that maybe the inhibitory killing immune receptors might play that game, and I saw really that the inhibitions is overexpressed up to F3. However, in the F4, it is not. And therefore, there is another reason why the NK cell is losing the capacity to kill. And it is not the regular receptors that are known and well published. And therefore, we decided to go to out of the box. At that time, we did kind of gene array analysis, and we isolated NK cells from different situations of the liver disease regarding the fibrosis. And to make the very long story too short, we allocated a very unique target that is additionally making the NK cells impaired. And this is the neurologine 4, NLG-N4X. The neurologine 4 receptor, we found that it is actually overexpressed in those natural killer cells that are obtained from patients with advanced fibrosis. In different shapes, either in mRNA or Western blot of the protein, we saw this elevation and overexpression of the NLG4 that actually caused to impairment to the NK cells, and I will show you how. By confocal microscopy, we showed that really this NK cell is overexpressing the NLG by red in this side, this case. Those are liver biopsy stained ones, but also when this is in vitro setting in which we took the NK cells isolated from the livers of patients with cirrhosis, and in this case we stained liver tissue. In all means, we can see that the NLG is overexpressed almost exponentially according to the hepatic fibrosis staging. And the more expression, the more depression of its function, and we show that in different settings and in different tools, that the more NLG expression, the more depression of activity. And we tried to figure out the pathways, and we did succeed to have so. Mainly it is the AKT that is depressed by the NLG overexpression, and therefore NLG4 now is actually defined as depressing many of the vital pathways inside the cell, in this case inside the natural killer cell, and it is impairing its function. We characterize that also from the other side. Actually, the natural killer cell, the NLG4, the NLG4 overexpression by itself is blocking the activity of the cell. However, the NLG4 should recognize the enemy, in this case, the fibrosis and fibrotic cells, the eto cells, the hepatic myofibroblasts, we can call them hepatic stellate cells, by ligand, and the ligand is beta-neuroxine. And in this case, we actually documented that activated stellate cells, they are really overexpressing the beta-neuroxine in the in situ settings from biopsies, in the in vitro setting of the LX2 cell lines, but also in the freshly isolated cells. And we see that actually the beta-neuroxine, which is the counterpart, the ligand for NLG4, is actually acts of fibrosis marker in the hepatic stellate cells, and we can use it as fibrosis markers of activation. It is not only a marker, it is also activating the stellate cells to introduce progression and proliferation of the fibrosis cells toward fibrosis. So what is happening, NK cells should meet the stellate cells and kill them. However, if they are overexpressed with NLG4 from one side, and if the beta-norexine is overexpressed in the fibrotic tissue in the another side, so we will have the story which is very mimicking the PD-1 and PD-L1 in the oncoimmunology. We showed how important the beta-norexine to actually activate the stellate cells in different manipulations shown in this slide. And actually, we could have a proof of concept that if we interrupt this immune synapse between the NK cells and stellate cells to improve activity by blocking the axes that have been actually uncovered NLG4 with beta-norexine, could reactivate the NK cells. We could improve the killing of the fibrosis and achieving lowerness of the fibrosis staging. Therefore, we showed that with the different ways that are including the siRNA silencing, they are including also the antibodies that we developed, which is specifically blocking the NLG4, and we are also using small molecules that we developed in order to interfere this immune synapse that is actually impairing the killing of fibrosis. This is another proof of concept that we have it from animal models. We are NLG4 knockout, and in knockout, there is no option of impairment for NK cells. NK cells were highly active, and we even could not achieve any fibrosis in those models, in those animals, knockout animals. In this situation, we took only the wild type and induced the hepatic fibrosis model. And by the way, in this case, it is carbon tetrachloride. And again, we used the same antibodies, and those antibodies could activate the NK cells and obtained anti-fibrotic properties, including improving the pathways intracellularly with the NK cells that have been isolated from the livers of same animals. To do another complicated proof of concept, we actually isolated liver tissue resident NK cells from donors. Those were actually the SCID donors that do have NK cells but do not have T cells or B cells. And then those NK cells, we sorted them out ex vivo. We isolated those who are NLG negative and those who are NLG positive. After that, we actually adapted them and transplanted them to donors who are completely knockout. Those are another model that we used, the nude ones. And actually, in this way, we could really show how the importance is of lacking the NLG4 within NK cells as compared to the having the NLG4, and the lacking NLG4 actually could achieve anti-fibrotic properties. Therefore, we do have now a very unique compounds, peptides, and we have also in the development antibodies that are actually achieving the anti-fibrotic effects and activating the NK cells. Luckily, I'm not showing you that this approach actually is not important only for hepatic fibrosis, but also for other diseases that are mediated by NK cells, for example, cancer. And we do have proof of concept that in HCC, in breast cancer, in colon cancer, it is playing the same game, and our compounds actually could activate the NK cells and achieve anti-cancer effect. This is open for collaboration as well. Now we are defining the same immune synapse in the IBD cases, so it could be a good opportunity for you, Carol, for collaboration. However, I didn't bring here the slides. We do have another novel target. You can look at my publication in GUT a year ago, in which we show that hepatic fibrosis and the fibrotic tissue, fibrotic cells, are expressing NTCP, which is the sodium taurocholic peptide 1 protein, which was important to activate fibrosis. And we could actually target this NTCP in order to reduce fibrosis in liver models. And now we also have proof of concept that fibrotic structures in IBD are also mediated, among others, within the structures with the NTCP interaction, and the therapeutic targeting of this NTCP might serve as another anti-fibrotic treatment in the panel of treatments that are offered for IBD patients. We are looking at the direct anti-fibrotic properties as well as the immune interaction. So you are also welcome to have a collaboration with this project. Honestly, we are now establishing such a collaboration also with the Cedars-Sinai, with the NTCP and the IBD, but we are more than happy to extend the collaboration. Carol, if you wish.
Yeah. Thank you,
So,
Doctor.
actually, with this, this is part of my team that they have the opportunity to come to the photography. Always the time that I am actually fixing for group photography, many of the teams are missing, mainly the surgeons. They are also always in the theaters, so they are really missing. So thank you for listening.